Good afternoon, everybody. Welcome to another edition of the AFR EMS case studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire, and today I'm joined by Dr. Kim Pruitt, our Medical Director.
Hi, Chief.
Thanks, Doc. And then also joined by Lieutenant Jacob Tapia
How
of
you
the
doing?
69th Cadet Class.
Yeah, best class ever.
Yeah, that's what we heard. All right. Well, thanks, Jacob. I appreciate you taking the time to come and talk to us today. Obviously, you're assigned to our Records Management Division, but you work regularly out in the field, and it sounds like you had a very interesting call about preeclampsia that we're going to talk about today when you were on a Rescue 19.
Correct.
So starting off, Rescue 19, Engine 19, you guys are dispatched to a 24 Delta 3. Obviously, that's the call that we start thinking a lot when we're on the way to it. Tell me some of the things that are running through your head and some of the dispatch info that helped you prepare for it.
Well, in today's day and age, with that little Siri coming over, we don't get too much dispatch information. So I read and I saw that she was 24 weeks. I don't think they mentioned anything about her being preeclamptic beforehand. But for me, most of the time, all of these turn out to be duds. So I get all ramped up, and then nothing happens, or they deliver before I get there. So it's pretty much a cool little drive over there, and we're getting ready to throw them into 5-5 and watch them go have their baby somewhere else. So
That's perfect. So I like the term dud, but you're saying typically when you get there, you don't have to deliver. That's what you mean by a dud.
that's correct.
All right, copy that. Just making sure. All right. So this was at the main event. This is at the bowling facility, then I assume, right? And
Yes.
you guys found that 32-year-old female. You said 24 weeks gestation. You found that on the notes, and you said she was lying on the floor, having some abdominal pain, and she also said headache. So talk us through that. What you saw, what you did after that.
yeah, so it's a pretty big facility, so we had some time when we were getting there, and then she was with a friend, and then all of their kids. I think when we arrived, because 7-8 went along with us, just because it was a 24 Delta, and when we got there, we heard over the radio that 5-5 was critical status, and we were going to have to transport. And so we started, it was loud in there. We were trying to figure out what was going on, and we opted to get her up and on the gurney relatively quickly. And about that time, her friend ended up saying that she was preeclamptic.
Okay.
And so trying to hear over the radio, see if we had a unit, and then listen to what she was going through. By the time we got her out into the rescue is when we started to do all of our treatment and take vital signs and all of that stuff.
Okay. And you got those initial vitals. You don't have to remember them, but off of your chart, it was 116 was her heart rate, and you had a blood pressure initially of 210 over 176. What started going through your head, or how did you change gears after you heard that, given the diagnosis before?
Yeah, so I know when people will say that they're diagnosed with a certain situation, that it may not active or be as active as one might think. But as soon as I saw the blood pressure, I was like, oh shoot, this girl's true to form preeclamptic. And then she was having some headache and some abdominal pain too. So we went ahead and started a line. And then I went through the protocols, which is awesome to have it on your phone nowadays. And I figured out that we had to give her 2 grams over the 10 minutes. And so we started to do that, and we opted to draw it up in a syringe, and then we filled it with normal saline up to 10 cc's, and then we just gave 1 cc a minute.
Okay. Doc, talk us through what we should be looking for recognizing preeclampsia, because I agreed with Jake, like that jumped out at me, 210 systolic, 176 diastolic. Automatically I'm zeroed in if that patient is pregnant, but it might not always be that obvious.
It can be really subtle. So it's always important to ask your female patients of childbearing age if they could be pregnant, if they are pregnant, or if they were recently pregnant. Because preeclampsia or eclampsia can be a risk up to 6 weeks after a delivery even. And with hypertension, you're looking for a blood pressure, a systolic greater than 140, diastolic greater than 110. And with this one, I mean, it was very clearly very high. But those are pressures that we see pretty regularly. So it's something good to keep on your radar for young females of childbearing age. The other call type I think this is important to think about in is our seizure calls. I know this wasn't a seizure call, but preeclampsia, especially the pressures like that, can very easily lead to seizures. And then technically that would be defined as eclampsia. But if you get called to a seizure on a young female, it's important to know if she just delivered. Maybe you see some clues about a baby around, a baby carriage or something, but sometimes you don't, and it's important to ask because that may change the treatment algorithm a little bit. You still treat a seizure like a seizure, but may need to add some mag on there too.
It's a good thought. So talk to us a little bit about the patient's history. Was this her first pregnancy?
No, I believe it was her second, and she had already delivered one before. The other thing that kind of changed a little bit was that the friend also said that she had been drinking. So the patient never divulged that information, but we were dealing with all of that, trying to figure out if the baby was going to have fetal alcohol syndrome or just some of those. How often does she drink? Was it just this one time? So we were just trying to gather all of that information.
Okay. So you talked about how you started out the treatment with the preeclampsia to probably prevent those seizures, right? So you started the MAG. Just talk us through, because not everybody's had an opportunity to give MAG in that specific situation. Can you talk us about how you drew it up, how you timed it out, and the way you made it work?
Yeah, so I was actually going to, I was just talking to Lieutenant Jonathan down at Station 7, and he was talking about giving MAG for respiratory distress. And so we had gone over putting it in the 250 cc underfill, and if you run it with the 10 drip tubing, you'll have 10 minutes to give it. But with the pressure that high, I didn't want to give her another 250 cc's. So we opted to go, our MAG comes in a 10 cc, 5 grams and 10 cc's. So we went ahead and drew up the 4 cc's to get the 2 grams. And then we just drew up the remainder to get 10 cc's of the normal saline.
And then doing it in pushes?
Yes.
Okay.
So, yeah, single boluses of a single cc, and that would get us over 10 minutes.
Okay. All right. And then any change that you saw in that form of treatment, or anything that changed vital signs wise or anything?
So we were pretty close. The event center is pretty close to the freeway, and then we jumped on I-25 and we got down there, I think, in like 4 minutes. So with all of the treatment and the time that it took, I think we had like 3 or 4 doses on board. And our second pressure, it had come down a little bit, but I don't think we had put very much MAG in her at that time. So I've always been afraid of MAG since paramedic school. It was always our last drug, and it seems like it's coming around to be used more often. I appreciate you coming on board, Dr. Pruitt, and helping us get more aggressive with our treatments, and really teaching us that we can use all of the tools in our toolbox. So that has been helpful. And now it's cool that we're pushing MAG a little bit more up front than in years past. So I was a little bit afraid, and I didn't know how she was going to respond if we were giving a little bit too much. Mm-hmm. But when we arrived at the hospital, we unhooked her from everything, and we didn't get another set of vitals. And by that time, everything goes so fast, they're shooting you up to OB on the 7th floor, I believe. And yeah, so we didn't get another set other than that to see how our treatment completed. The one thing that I would mention is once we got there, my driver ended up thinking that we were done with the dosing. And so I think we had given her 5 cc's at that time, and then he just went ahead and threw away. So just remember that we can still give the medication when we're at the hospital, and then fulfill that remainder of the 2 grams over the 10 minutes.
That's a unique thought, and that's what I wanted to just check with Doc is thinking that through. You already have a patient whose pressure is through the roof. You really don't want to overload them with more fluids. So is that a common tactic, and is that something you should be concerned about in that 250, or are you okay either way, whatever you're comfortable with?
I was actually just sitting here appreciating your ingenuity and figuring that out and the alternative way to dose it in the safest way you thought possible. It was really good quick thinking on your part and actually a lot of math. MAG is the right treatment for this, and so if it is a little too much math or it's complicated, like a 250, when you look at it, it's not necessarily that much. It's about a little styrofoam cup full of fluid, and I think in her big picture, it's probably okay to just go ahead and put that 2 grams of mag inside that 250 and just keep it going that way, along with your radio report and all the other things going on. And like, say she had a seizure and you had to like start drawing up Versed, that's nice to just kind of have a fire and forget option to let it keep going. But I think what you did was actually really brilliant.
Yeah,
So,
it was good the first time
yeah.
I heard it when you were describing it.
Yeah.
I was like, that's pretty good, but you're right, probably makes you even more task saturated. You don't have to worry about it. So just a good learner, but a great job on that. So you were prepared for seizures. You knew how you were going to treat those. You were kind of, I know the pressure went down a little bit, but that was your biggest concern, your biggest life threat for her would have been the seizures, and you guys were planning on treating that how?
We would have went to Versed. We would have started her off with 5 milligrams and pushed that IV probably.
Perfect. Yeah, that would have been my next step as well. And you talked about destinations because you guys ended up on one of the floors at the hospitals. Where did you end up going with that patient?
So I gave the radio report just like we normally would, and then when we got there, everybody meets you at the front door. They're like, "This is the OB patient. Okay, you're going to go up to the 7th floor." And then we had a little bit of trouble with our key card not getting us into the area with the elevators, but the staff was helpful enough to get us up there.
Is that at Press downtown?
Yes,
That was
that's
at Press.
correct,
Okay.
yeah. Sorry.
Yeah, no, that was great. So just making sure we're going to a hospital that has a NICU. So if we do delivery afterwards, then we're prepared for that. So Press downtown is an option. UNM. Loveless Women's are all great options. It's a great point about the key cards. I'm almost positive our key cards probably won't let us into any L&D floor. That's probably for security purposes. So just knowing when you get there, call your radio report like normal, and then they can escort you up. So fantastic job. Anything in terms of that you would do differently, what you can inspire other officers who encounter this call to do if they have it?
No, I appreciate Doc's statement on being able to give, well, actually taking into consideration how much 250 cc's is. I'm always considering I'm putting it directly into the bloodstream, so it's not going to be peed out or in a relatively quick amount of time. So it's good to know that we can give 250 and it's not going to affect the patient in any way. And so it would have been helpful had I understood that before, to be hands-free, because once you tie up 2 medics, especially the officer trying to push and then give radio report and carry all of the stuff that you're going to do, you have help with the basics, but it is nice to have a set of hands that are free to do whatever you need to do.
Yeah, great. Well, great job. I appreciate you coming out to talk with us on this interesting case. It was really good. And I want to encourage anybody who has a case who's interested, reach out to us. We have a SharePoint tab under the EMS section to submit a case study or reach out to your 7-8. And until then, we'll see you next time. Thank you, everybody.